Someone literally stopped me in an airport bathroom and said, Dr. Mike, please keep reacting to the pit. So here we go, episode 6. Let's get started. Pew.
Mom, stop! This is what you had in mind for your fun weekend with your aunt?
All right,
I was trying to help her. No, what would have been helpful is telling me that my daughter is pregnant. Instead, I find out from a confused teenage boy. Jackson told you? Yeah, he did.
Whoa, everything okay in here?
This is Mrs. Wheeler, Christy's mother. Lynette is Christy's aunt.
She doesn't want to have this baby. This has nothing to do with you.
Okay,
no,
maybe
I
we'll just
called
take it-
Aunt Lynn. Okay, I don't want to be a teen mom.
This is a full-on Maury episode live in the ER. And these things do happen. This is very realistic, and it's an uncomfortable portion of working in primary care.
Dr. Rabinovich,
Gloria,
this is Dr. Tracy Morris, Regional Manager of ECQ America.
the contract management group.
It's a pleasure to meet you.
Likewise, but if you'll excuse me, I'm a little slammed as per usual.
We were upstairs with the executive team going over a proposal.
A proposal?
We're interested in having your emergency department join us.
The 500 or so ERs you have aren't enough?
I don't know exactly how this works, but basically these contracting services get hired by the hospital in order to supply them emergency room physicians. And this could have some benefit, especially for the hospital groups to make it easier to staff their ERs, but it could also make each individual provider less powerful. So my general consensus is that this isn't great for the individual providers, but great for the hospital systems. But I have heard certain people take different sides of this debate.
Your contract management's corporate mandate is profits for shareholders above everything else, yes?
Robbie?
Your hospital's board was very impressed with ECQ's metrics on patient satisfaction, throughput time, and billing collections.
Does your proposal include the part where you cut the pay for all my doctors?
Maybe I can find an incentive for you. How does regional medical director sound? Lighter workload, better benefits,
Yeah, at the expense of screwing over your colleagues.
stock options,
Did you go to business school or medical school?
both.
And that makes it even more sad.
I can't believe you're seriously considering this.
Bottom line is our current numbers aren't good and theirs are.
Just because their dashboard is pretty doesn't mean it's good for patients.
If you want to keep the CD, improve metrics. There's a lot of OFI. Opportunities for improvement.
Well, you could have just said that.
I need you to care about patient satisfaction.
I would love nothing more.
I don't understand what about, I mean, we are only seeing one day, but what about his relationship with his colleagues, his staff, and his patients show that he doesn't care about them? It's unreasonable asks like this from administration that cause all the tension with providers. And a big part of this that created this as an issue in healthcare is because physicians left the C-suite. It used to be physicians that ran hospitals, hospital groups, the businesses that surrounded healthcare. But lately, we've seen people with business degrees fill those roles, or maybe non-physician medical providers fill those roles. And as a result, you're losing that clinician touch, or at least that clinician gained experience that those providers had and brought it to the table.
But right now, the average wait time is 6 hours, and that's before you see a doctor. You need to hire more staff so we can open more inpatient beds. Are you prepared to do that?
I need you to improve scores with the resources we have.
You should improve the ER. The doctor should make sure that all of the training gets done, the diagnosing gets done, patients are treated. Your job is to staff the ER and make sure that there's enough supplies, staffing, support for patients. All those things are equally important.
Maybe you need some time off.
Hey, we got a ladder fall. A couple minutes out. Yep.
And people wonder why physicians are burning out.
What do we have?
45-year-old Silas Dunn fell off an 8-foot ladder. Right chest hit the carpeted floor. No LOC, good vitals. No meds, no allergies.
Dr. Santos, how are you doing?
Fine. My wife called 911. These guys said this was all necessary, but I can walk.
We're gonna keep it on until we get you all checked out.
Yeah, you want to make sure this cervical spine is stabilized because you don't know until you rule out a fracture. When you rule it out, then you can remove the protection. Also, there was no loss of consciousness, but that doesn't rule out that there is no bleed or the fact that there's no concussion. In fact, we do certain head protocols. One of them is known as the Canada protocol in order to decide who should get a CT scan in order to decrease the over-ordering of head CT scans.
What are you thinking?
What made him fall? Could have been cardiac or neuro. Any headaches?
I was a little dizzy.
He needs a head CT, EKG, and troponin.
Exactly.
Yeah, if you're dizzy, that means you're symptomatic, and a symptomatic loss of consciousness would warrant that. Obviously, you need cardiac testing, neuro testing from imaging, and that will give you at least the initial rule out of things that could have predisposed someone to faint. The most common reason that people faint that is benign is called vasovagal syncope. This could happen as a result of arteries not tensing up fast enough when you stand up, and therefore you don't get enough circulation to the brain. Or it could happen as a result of bearing down, like when you're using the bathroom. Sometimes it can even happen just in a hot environment, and part of it is unknown. There's a lot of unknown factors. Another way that we rule out a heart attack is drawing labs called troponins. They're usually drawn serially every few hours in order to see if there is a substantial raise in troponin. Because these are muscle proteins that come from your cardiac muscle, we're really doing it to see if there's damage to the cardiac tissue. You'll end up seeing an elevation in these proteins.
I was installing a lighting fixture in the
Dr. Santos on E-Fast, please.
Dr. Garcia, can you spell world?
W-O-R-L-D.
Start with D, spell backwards.
D-L-R-O-W.
Excellent. Your brain is fine.
Pulse 92, BP 132/78.
Basically, he's oxygenating well. His heart rate's a little bit fast. It's not technically tachycardic because it's not over 100, but at rest, it should be a little bit lower. He's probably anxious. Blood pressure is mildly elevated, again, likely from anxiety, not something we're going to be addressing in the emergency setting.
No pericardial effusion.
No pericardial effusion means that there's no swelling or excess fluid surrounding the heart. So in a situation like this, you also want to get an EKG that will show you if you have ST elevations or depressions, potentially signaling some sort of heart attack. You could also have certain arrhythmias that could predispose someone to syncopize, aka faint, like heart block is a very popular one, but there are obviously others.
Oh, tender?
Yeah.
Okay, ribs 7 and 8, MCL.
You probably cracked a rib or two.
Check for lung sliding. It could be a pneumo.
Yeah, so when you have rib fractures, unless the rib has been displaced, meaning that the rib is completely unaligned, potentially poking the lung, you're not really doing much. The danger of a rib breaking is that what Dr. Robbie said here, pneumothorax, where the rib ends up puncturing the lung collapses. But usually in a situation like that, person's oxygen saturation drops, their pulse goes up in order to compensate, perhaps their blood pressure. But most importantly, you're gonna see clinically fast breathing, difficulty catching air, and we're not seeing that, so very low risk. You're also gonna be able to hear that by putting the stethoscope and listening in all the lung fields to see if you have decreased breath sounds on one side. Obviously, X-ray will be more definitive in that regard. In general, rib fractures, we don't do anything. They just heal on their own. Very painful. Pain control is of utmost importance. An early use of incentive spirometry is very important here. Basically, what you're trying to do is avoid pain, so you start breathing in real shallow, not deeply. And that creates a problem because you're not activating your full lung, and you could actually end up developing atelectasis, the dysfunction of the lower portion of the lungs, because you're not using them. So you want to use incentive spirometry where you breathe against this pressure gradient to make sure that you are using your lungs to their full capacity.
My wife has a whole list of things she wants us to get done.
I'm afraid the only home renovations you're going to be doing in the next couple of weeks are the kind you watch on TV.
Can you tell my wife that?
Lungs are up. What's your sign? Scorpio.
Yeah, let's go Scorpios.
Spicy.
Everyone has that reaction. They either say, oh, Scorpio, hate you, or they go, oh, Scorpio, cool, spicy. Why is Scorpio the most polarizing zodiac sign?
Tier 1 trauma, ETA now. Tier 1 trauma, ETA
Call me if anything
now.
changes.
Miles Hernandez, 18, unrestrained driver of the stolen ambulance. Right chest, left leg injuries. Short of breath, sat 91, tachy 120s, BP 105/70.
Breath sounds bilateral, but lots of striders. Set up for intubation. We gotta fix this fast.
Posterior hip dislocation. Good pedal pulse.
We need induction meds, ketamine and rock.
Ho, look at this clavicle.
So it looks like he has a broken clavicle, potentially leading to a pneumothorax, or perhaps bleeding inside.
A sternoclavicular dislocation?
It's compressing his trachea.
Reduce it, see if it helps his breathing.
I'm curious how they know it's a dislocation as opposed to a true fracture before they get x-rays.
Board morphine, draw a rainbow, type and screen.
Heart rate's 125.
Starting to get on the airway. Collins, E-Fast.
No blood in the oropharynx.
Clavicle is dislocated posteriorly. Chlorhexidine swab.
BP's 108/74.
All right.
Chlorhexidine is how we do disinfections of the skin. His blood pressure is stable in this regard, but the fact that he's experiencing tachycardia, fast heart rate, that signals something is going on that he has to increase his cardiac output for.
Your collarbone is pushing against your windpipe. We're gonna pull it back up. I'm gonna inject an anesthetic. You're gonna feel a pinprick and a big burn.
Ugh, the area where he's injecting it. I don't know. You gotta be careful there. There are blood vessels there.
All right, go deep. You want to get a really good grip on both sides of that bone.
Oh. Got it. All right, Miles. It's gonna hurt for a second. You ready?
Oh, I've never seen this done.
Squeezing is good.
Yeah, when they're bringing him in and they're saying they hear Strider, it's some kind of whistling that they were hearing that led them to think that there was compression of his trachea. How they knew that as fast as they did was very impressive. Usually in most scenarios like this, they would need to get an x-ray in order to confirm that. I don't know, maybe an ER doctor will feel otherwise, but.
This was a terrible idea.
Oh, is this some kind of butt implant?
And now I'm having a panic attack.
Excuse me, Dr. Moore.
This is why I always have the drapes drawn. And even if he didn't open the door, it's still see-through, so people are looking at the patient. Allow the patient to have some dignity.
She found the guy on TikTok. He did the injections in his living room. She thinks it was maybe silicone cock from Home Depot.
Yeah, I've seen individuals get like concrete injections, and not in my own practice, but I have had a patient that got some type of injection. I don't remember if it was some kind of fat melting injection, but she ended up developing a buttock abscess that essentially put a hole inside her buttock as a result of the infection. Please, if you're gonna do cosmetic surgery, be careful.
She's tachycardic and tachypnic. I think it's a panic attack, but if a piece of silicone hit a vein, she could have a pulmonary embolism. We should scan her.
Good.
It would be reasonable to give her an anti-anxiety medication and see if it comes down, and therefore you're not scanning her and you're saving her the radiation. I would have said that as a preceptor, at least presenting it and then seeing what my resident or trainee would say back and say, no, I think we really should scan. I'm seeing systemic signs that could be pointing to a PE. But right now, it's just like a shot in the dark.
Is my family here yet?
I'm not sure. We'll check. How was the CT?
Head and neck normal, but tech found a small hemothorax on the right.
Oh, so he has a little bit of bleeding inside his thoracic cavity.
Oh, what's that?
It's a little bleeding around the lung where you broke a rib.
He's also been more short of breath since after the scan.
So maybe we can throw a little stethoscope right there and see if there's decreased breath sounds.
Silas?
Uh-oh.
Hey, Silas, wake up.
Lost the radial pulse.
Thready carotid. His BP's crashing. I think he might need a chest tube.
Why do residents, I mean, I know why residents get excited to perform procedures, but it's like, don't get excited at the patient's decompensating.
BP 72/44, pulse ox to 89.
I would be checking for a pulse. If there's no pulse, I'd be doing chest compression.
Normal head CT, small hemothorax on the right.
Which has now turned into a huge collection of blood. Prep for a chest tube, 20 French. I would love to do the chest tube.
You got it. I'll guide you.
Sats are low. Should we intubate?
Not until after the chest tubes, we wouldn't want to cause a tension pneumo.
You won't make that mistake again.
Remember, small damage to the lungs, if you put a lot of pressure in the lungs, can become a big damage to the lungs.
Template to Dr. Santos.
There's a lot of breast tissue.
Again, why is no one wearing masks? I guess it's to hear the characters talk and to keep them recognizable. Just like there's bodily fluids that can come out.
Mom Kelly next.
Oh! That's why you don't, I mean, she's not wearing open-toed shoes, but man.
Oh my God, are you okay?
Oh, that's gotta hurt.
Leave it, but.
Okay, I'm stepping in.
Nope, you're not the lunch. I got this.
This is the funniest episode that we see. I hate to be laughing at Paige, just the way that they're handling it. God, every time poor doctor wants to do a chest tube, something bad happens. You gotta hold on to those sharps. We actually talked about her mishandling sharps, I think on the last episode.
No need to hover.
Okay, We'll be next door if you need me.
Infectious control, sub her out, wash her wound, ask the patient if they're okay to be tested for communicable diseases, decide if you want to be put on post-exposure prophylaxis. His administrator is mad at him for patient wait times. All their staff is getting bloodborne infections from other patients. Do you know what lawsuits are gonna come from this? Where is your occupational safety team?
Sats and BP look perfect.
We ready to go in here?
Getting there. Okay. You're gonna pretend you're a pirate with your foot on a keg of rum.
Are you serious?
Yep. This is the Captain Morgan technique for hip reduction.
Who's Captain Morgan?
He's a imaginary pirate that sells booze.
The guy in the rum bottle?
I'll stabilize the pelvis.
That's a lie. Med students all party. Honestly, med students party too much. I remember like all my med student friends, even in different med schools, every time a test was over, they'd all get really drunk. And like, look, I drank, but like, I don't know how they had the energy. Cause like I studied all night, I crammed, so I had zero energy. I looked forward to sleeping more so than drinking.
Actually, I might just...
I love that she hands it to the attendant. You're the attendant, go see more patients. You're in trouble with your administrator.
You are gonna put your right leg behind his knee.
Like this? Oh.
Yeah, and you are gonna use your leg as a hinge to put anterior force on his femur.
Physics.
Push down on the lower leg with your left hand.
You got this. Put your back into it. The hip is a big joint with lots of muscle stabilizing it.
Yeah, okay.
The fact that he's sedated makes the process easier. Sometimes when a patient is awake and they try and do, let's say, a shoulder reduction or something, the muscle tightens up significantly.
Boom!
A good clunk means a good result.
That is what a hip reduction feels like.
Thank you.
If this happens to someone who had a hip replacement, it's incredibly painful. In fact, I think we reacted on our Bondi Beach rescue episode. Oh my God, they're not ready for the level of pain this person's about to experience. And it was incredibly painful. But again, once reduced, feels much better right away.
I hear you have an 85-year-old patient who may have been abandoned by her primary caregiver.
Well, maybe. I hope not. I don't want to say this is elder neglect, but...
Don't jump to the worst case yet. I'll see if I could get a hold of any other family members.
Yeah, I've had terrible situations where I saw patients in my practice and the family no longer wanted to care for an individual, or they were keeping an individual alive because they were collecting Social Security checks. There were all sorts of really messed up scenarios that don't qualify as neglect or abuse. And as a result, there's sometimes your hands are fully tied and you try and do the best for your patients, but you are sending them out of the ER or an admission knowing that there's a high probability that they'll be back not in the not so distant future. Now we're trying to get better at this with dispo planning, which means sending them to either a subacute rehab, a nursing facility, home with some kind of family, but not in every situation do we have good follow-up like that.
Nick Valley's cerebral perfusion study's back.
As he presumed, I'm assuming the child is dead.
No blood flow past the brainstem. Okay. Let me know when the transplant people from court arrive.
Will do.
So I have the results of Nick's cerebral perfusion scan. Unfortunately, it shows that there's no blood flow to Nick's brain.
Not a fan of delivering the results in that way. When you sit down with parents that are anxiously, or anyone, patients that are anticipatory, sitting there waiting for you to give them some sort of news, and you present technical information first, it doesn't help the family. They get more confused. And the anticipation builds up, and it can get really high, and therefore they can get really angry. While it may feel good to say some technical information because it feels like it's disarming, in reality, it could make patients feel worse because they're not sure, is that good, is that bad? And that sort of anticipation raises the reaction that they're gonna have. Instead, I sit down right away. We think that there is no brain activity in your child. And when they have a big reaction, then you could follow up with a technical analysis explaining what's going on, but you have to be straightforward with the results right away.
What am I looking at?
It might help you if I showed you.
Yeah, again, after the fact. So give them the analysis, the read of what you've seen and what it means, and then show them this.
This is a healthy brain. See the black? That's blood flowing to the cerebrum. When there's no blood flow,
It's White.
Yes.
He's brain dead.
I am so very sorry.
Why allow them to come to that conclusion when it's your job to deliver that conclusion?
So he's not coming back.
No.
Again, he's letting them come to the conclusion. This could have all been bypassed.
John, I want to introduce you to Emma Isaacs. She's a family support specialist that works with me, families in the emergency room. She's here to answer any questions that you have and to keep you informed.
Hi, Mr. and Mrs. Bradley.
Oh, John and Lily, please.
Okay, I'll let you talk.
Doctor, can you stay, please?
Sure.
In a situation like that, you have to be careful because if you say sure, you're committing to staying the entire time. That entire time could end up being 45 minutes and you'd be missing a lot of patients and not performing your duties. So I'm not saying staying is wrong, but quantifying how long you're gonna stay so that you are agreeing to what the patient request is. Say, sure, I'd love to stay for a few minutes because there's other patients. If you say yes, they expect you to stay the entire time. And if you leave early, it could be a sign that you're being disrespectful.
I'm so sorry for your loss.
Understanding where the patients are in a given moment is very valuable because some patients can be in a situation where they have a significant disconnect between what's happening and what they believe is happening.
Your son's driver's license indicated that he wanted to be an organ and tissue donor upon death. That means he's given his permission for that.
No, I don't want to talk about that. No, he was too young to make that kind of decision.
I can understand why you would think that, but he was 18.
No! You didn't know him!
Don't like starting off a sentence in agreement and then changing it with a but. It basically, in a situation where a patient and a patient's family is being emotional, anything you said before the but immediately gets removed. So saying that, I totally understand where you're coming from. Why do you think he signed up to be an organ donor on his driver's license? Is the next line of questioning you want to move towards.
He is still my son!
Because then you don't have this, and instead you have them wondering, why did he want to donate? And now you're getting that conversation moving in the right direction. Again, you're not being manipulative here because he actually did want to be an organ donor. You're just trying to do it with creating the least amount of friction and discomfort for the family and maximizing the benefit of the situation.
Hi. Look at this beautiful black queen. Are you our doctor? Thank you. Yes, I'm Dr. Heather Collins, and I take it this is Dylan.
Mm-hmm. And I'm his mother, Tina.
It's nice to meet you both. Dylan, when did the pain start?
Started like an hour ago.
Did you get kicked or hit with a ball or anything?
No, it just came out of nowhere.
Oh no, is this a case of testicular torsion? So testicular pain needs to be ruled out immediately as it could be testicular torsion. The spermatic cord that runs from the abdomen down to the testicle actually has the blood vessels there. If that wraps on itself, it could actually create a situation where it cuts off circulation to the testicle, and as a result, the testicle starts dying. And this is a surgical emergency that you need to unwrap the testicle. There are ways you can try and unwrap it without surgery, painful, and can be tried if the provider is experienced enough. And interestingly enough, individuals who have had testicular torsion are higher risk for getting it again. Sometimes surgeons will actually fix the testicle in the area. And there are certain deformities like the bell clapper deformity that can predispose you to having a higher risk of testicular torsion. And people are probably wondering what causes testicular torsion. Pretty much anything. It can happen during coughing, sneezing, being athletic, or just sleeping.
I need to do an ultrasound to make sure your testicle didn't twist on itself and cut off the blood supply. Is that all right with you?
There's also a reflex that we check for. It's called the cremasteric reflex, where you rub the inside of the thigh, and the cremasteric reflex should raise up the testicle. If it doesn't, that could be a sign that there is a testicular torsion.
We're going to squirt some medicine up your nose. It'll help you relax and help take away some of the pain.
And do it. Okay, Dr. Collins says it'll help.
I know, Mom. I heard her. My ears are fine. It's my junk that's killing me. Please.
Okay, sorry, baby.
Come on, bro.
There's no blood flow here at all. Is that dangerous?
It is. It's a surgical emergency because an ultrasound does show blood flow.
If it goes untreated for more than 6 hours, he could lose a testicle.
I could lose my balls.
One testicle. And we're going to try and prevent that. What the hell were you doing, Dylan? I'm taking that lock off your door. It's difficult to know what causes a torsion, unfortunately. Dylan, hey, it's really important that I try and fix this now.
Okay.
Most of the time, the torsion is to the inside, so we rotate outward by opening the book.
As you can imagine, it's very uncomfortable. But again, I really hope the curtain is shut.
That's good.
I've never performed this procedure. I obviously know it exists, but...
I'm okay now.
It's fixed. For the time being, we need to admit to urology. He'll need minor surgery to tack it down and prevent it from happening again.
Maybe an orchipexy? Orchipexy? Orchiopexy. Orchiopexy. Come on, Mike. It's funny, we called like step by step exactly what happened in this episode.
Please let me know when you get your own office because you have been wonderful.
And you have a great relationship with your son.
Yeah, so you're gonna break the lock to see what he's doing.
He is my heart in human form. Oh. Do you have any?
Not yet, but hopefully soon.
Neurocysticercosis, a parasite in your brain.
Neurocysticercosis? Did he infect pork?
I thought I just had a migraine, but I have bugs in my head.
Well, not exactly. You had larvae from a pork tapeworm.
Yo, what up? Look at that. Making rare diagnoses live on the YouTube.
A worm.
But it's dead and long gone. What we're seeing on the CT is scarring around those dead cysts.
Can you fix it?
Unfortunately, no. The little calcified spots will stay there.
So there's going to be a worm graveyard in my brain forever.
Yeah, but they're resting in peace.
I'm familiar, it's called Tinea solium, the pork tapeworm, but I don't remember what the treatment for it is. Is it like albendazole? Let's look it up. Albendazole, what up?
Oh, man. What a day for you.
Yo, just diagnosing left and right today. Just slinging treatments.
I was just coming to check on you two. Are you leaving?
Yes, we're going home.
Were you able to come to a decision?
Chrissy's gonna stay in school until she's due.
Is that what you want?
Also, she's 17. When's her 18th birthday? Is it next week? Last when we checked on this episode, abortion was legal up to 22 weeks? 23 weeks in Pennsylvania?
Morning sickness.
There are conditions called hyperemesis gravidum that is brutal, gravidarum, where you're having severe nausea and vomiting throughout pregnancy. And in those situations, there are specific medications that we do use. What is she feeling?
I'll be right back.
Dr. Robbie?
Did she feel something
What's
in
up?
the breast? The breast?
Silas's chest tube output is slowed down after 650 cc's.
Good.
But on re-exam, I noticed some breast enlargement. Bilateral and symmetrical with no palpable masses.
What's in the differential diagnosis for male gynecomastia?
Definitely alcoholism, but then there's pituitary and gonadal tumors or pathology.
So what do you want to check?
LFTs for alcohol abuse, and for the rest, hormonal levels, estrogen, testosterone, prolactin, HCG, progesterone.
In the ER? Maybe draw some initial labs and give the follow-up diagnosis to be followed by us in the primary care setting.
Hello, Mrs. Kitajima. How are you feeling?
Ginger, please. I'm getting tired.
Why is she just chilling in the hallway in a wheelchair?
Where's my daughter?
I'm sorry, but I don't know. But we're doing everything we can to find her.
Great answer. Fantastic answer. Pure honesty without getting the patient worried.
Hey, Christy. It's Dr. Collins here. Is everything all right in there?
No, I want the pill! Absolutely not.
Eloise, why don't you find a place to sit and I will...
You're gonna what? Give my daughter the abortion I've forbidden?
Hey,
what's going on? Christy's texting. Is she okay? You can't be back here. She's begging us for help.
Family room. Family room. Bring them to family room.
Let's take it down a notch. This is none of your business. I am not abandoning Christy. Get the f out of here. Yeah. Hey, ladies, that's enough. She is lying, Doc.
Security. Family room. The Nazis did some terrible things, but did you know that there's a group of doctors that actually trick the Nazis and created a vaccine? Click here to check out that animated story we've told, and as always, stay happy and healthy.